Thanks everyone for being here. My name is Denise Balch, and I am the Executive Director of the Prior Authorization Framework and Accreditation Program. Many of you, or most of you, will know me from wearing different hats with Connects Health, running webinars, blogs, podcasts, in-person events. I also work with the Canadian Association of Optometrists, so I've been doing a lot of work there. And of course, now we're here to talk about prior authorization. I'm going to be joined today by Alan Birch, who's the Associate Director of Provider Solutions at Centrex. Alan joined us as a panelist for our first in this 3 webinar series as a panelist. And Shanta Zurak, who you haven't heard from before from Prior Auth, she's the Director of Reimbursement at Sensura, or Innomer Strategies. And both she and Alan were on our working group in putting this guide together. So I'm very pleased that they have been able to be with us as panelists so that we can have a discussion with them after my presentation. I think it's in the evaluation too, but if you want to know more about prior authorization, you want to know how to get involved, you want to know how to talk to your clients or to payers, insurers, and I know we have at least one on the line, then please call me. Email me, call me. You can find my contact information. Nathan will make sure that that's in the email that he sends out, or you can find me via the website, which is priorauthframework.ca. Okay, let's get this party started. So, I think when I look at the PAFA program, particularly when I get to this accreditation part of the program, it is challenging. It's not an easy standard to meet. But when I was putting this together, I really was thinking that, yeah, PAFA sets a high bar for payers, but patients and their healthcare providers deserve that. And plan sponsors are paying for it. They deserve that too. So yes, we are setting a high bar, although many of the practices I'm sure payers are already doing. Um, but I think we should expect that from our payers. With the amount of money that we're talking about and the long-term agreements and relationships that plan sponsors have with payers, payers have a big responsibility in payment of claims, whether they be drug claims or other claims. And so I think that setting that high bar is important for our payers. This is just a bit of a graphic. We showed this last time, and I think that it really does help understand what the prior auth framework and accreditation program looks like. So we went through the guiding principles and the governance, and we did kind of a quick overview in webinar 1. And then in webinar 2, we really focused on that membership and accreditation aspect of the program. And in webinar 3, we're really getting into the guts of the framework. And then we're going to talk a little bit about reporting and industry and the industry survey that we'll be doing later this year. But this does give you a really good overview of the structure of the program. So we all know that prior authorization is to manage a specialty in high volume drugs, including GLP-1s. And that has created a rather complex environment. So this is just an image that I've shown in the last 2 webinars, but I think it's worth repeating that there's all these things, all these stakeholders involved in prior authorization and reimbursement of specialty drugs. We have over 500 drugs in the marketplace right now that could be classified as specialty drugs. Around half of those are covered under private plans. A lot of them are covered publicly. And right now we're still in a paper-based environment. That causes a lot of problems for the stakeholders that are involved. And it's created a whole industry around patient support programs and specialty pharmacy. There's the public sectors involved in this too. They usually call it special authorization rather than prior authorization. But there's certainly a whole complex process for public payers as well. You'll know that in 2020, I was a co-author of a white paper on prior authorization. So this is really what got this party started. And the role of simplified prior authorization, which was created following the white paper, has really been a significant amount of advocacy in terms of blogs, podcasts, webinars, and education through the simplifypriorauth.ca website, which is still up and running. It's in French as well as English, and it is accessible, meets accessibility standards. And we've had a lot of dialogue, ongoing dialogue with stakeholders, whether they be payers or payer associations, um, uh, and physicians, patient groups, lots of different people involved in the prior authorization process or impacted by it. We've also looked to sourcing prior authorization solution providers, and there are several in the marketplace. We've done had most of our discussions with OKRX, and as most of you know, they're working with Green Shield now, and will probably be the first entry into the marketplace for full prior authorization, electronic prior authorization. And then what we're here to talk about today, which is the prior authorization framework and accreditation program. And this really completes the mandate of the Simplified Prior Authorization Initiative. We've really addressed each of the mandates or recommendations in that 2020 white paper. And as I said, the prior auth framework and accreditation program is really completing the full circle of the role of simplified prior auth. You will still hear messaging from Simplified Prior Auth because it is more of an advocacy and education group, and prior authorization, of course, is something quite different. So let's get into the nitty-gritty of a prior authorization. So again, just 2 more slides on a review. Just bear with me here. I just want to make sure that those people that didn't attend that first and second session have a bit of an idea of what we discussed. So what is PAFA exactly? Who owns it? What's its status? Well, it is a Canadian nonprofit that's developed what we think is a very credible framework for efficiencies in prior authorization. And along with that comes an accreditation process for payers who adopt the efficiencies, and many of these efficiencies may already be in place, but who adopt these efficiencies. So they get that recognition for following that framework, and there are lots of benefits that we're going to talk about later. Right now, I own that Canadian nonprofit, but for those of you that may not know me very well, I am getting older and I am planning on retiring in a few years. So while I may still be involved in PAFA, maybe on the board, I'm definitely looking to have this initiative taken over by someone else in the longer term. Short term, medium term, I'll be around. And so what is the goal? It's to engage payers to make positive changes in their prior auth claims process and practices. And who benefits? Well, from our perspective, we think everyone benefits. And everything that I've read, everybody that I've talked to would support that. There really hasn't been any negative comments about improving the prior authorization process or electronic prior authorization. We'll talk a little bit more about that later. And then membership and management, just a couple of weeks ago, we went through, which is not very well noted in the guide. We wanted to keep it pretty low key, but is the fundamental values of putting this framework and accreditation program together was we wanted to make sure that we were being fair, that we were current, and so we don't look at the guide as a stagnant stagnant framework and accreditation. It's definitely going to be developing and changing over time, that it needs to be relevant to the current environment and achievable. So we didn't want to put anything in there that was totally out of reach, and that's one of the reasons why we have 2 separate accreditation levels. In terms of the guiding principles, we looked at communication, transparency, and fairness, consistency, efficiency, and their development. So the sources for those. And then we looked at who's on the board of directors, who's on our framework and accreditation advisory board. And I did mention that there are 9 seats on that, and we are holding 2 spots for payers. So those discussions are ongoing right now with a couple of payers. We'll see how that turns out, but it may take a little while, but I'm confident that we will get 2 payers on the advisory board, and so that they can make a contribution to the framework and the accreditation process. So this advisory board is going to be regularly reviewing the guide to make sure it's up to date and accurate. They're going to be involved in the creation of the survey, which I'll talk more about, and the selection of those individuals that will sit on the accreditation panel. And then, of course, we have the accreditation panel itself. There will be 4 individuals sitting on that. There will be no payers on that. And that group will review accreditation applications from payers. Membership and associate membership benefits, we went through that, and that's also on our website. And then we briefly reviewed the accreditation levels and the process. So what are we going to look through today? We are going to get into more details on the framework and accreditation. I'm going to talk to you about the 2 levels, the administration efficiencies and electronic prior authorization, what that looks like today. And then we're going to look at some future opportunities that may be included in the future or may not. There may be other things that we haven't even thought of that might be included in the future. We'll talk about member accreditation and the timelines for that, reporting and industry survey, what that looks like. And then we'll talk about briefly about the benefits of change and from each stakeholder's perspective. And then, of course, we'll have our discussion with Alan Shanta and, of course, everyone here. So let's look at the framework. Little sip of coffee first. It's quite a complex document, and certainly how the framework is described, we've put it in a table format so that it's not quite as complex. It's easier to go through. So I've tried to do my best with translating that into slides that we can go through within the time allowed and that are kind of easy to explain, for me to explain and for you to grasp. So in terms of administration efficiencies, this is level 1, and this is really where most payers or almost all payers are today. EPA is a little ways off yet. I'll talk more about that later, but really where we're at realistically is payers looking at administrative efficiencies certification. So the goal of this is to create those efficiencies and to a better understanding of payer admin practices and process for all stakeholders. So we just want to make the process, make sure it's transparent, make sure there's good communication, and that where efficiencies are possible, that those are created. We've developed the admin efficiencies based on the feedback we had in the research for the 2020 report. And one-on-one discussions with prior authorization stakeholders between not only the time that we did the report, but after that, when we reached out to additional stakeholders. And we also looked at practices, guidelines, and state laws in the US. So if we think that Canada is complicated from a prior authorization perspective, the US is way, way worse. Prior authorization has often been impacted by state laws with different requirements. We actually have in Appendix 2, there's a link to some of the information that we looked at. And there are some guidelines and practices as well in the US. So what exactly does administration efficiencies address? Well, while I am going to go into it in more detail, at a high level, we're looking at ensuring that payers are identifying medications that are subject to prior authorization, the access that plan members and patients have to information with respect to the medications that require prior authorization, the claims process so that they understand that clearly, and how to appeal a denial if their claim is denied. We also looked at timelines and also continuation of coverage policies. And I know that this has come up with the Canadian Life and Health Insurance Association and their members, certainly on change of carrier. And that's been quite problematic in the past. There hasn't been any collaboration, or there hasn't been any formal collaboration between payers on change of carrier for those individuals that are on a prior authorization product and have been approved for prior authorization. They can fall through the cracks on change of carrier. And so that's something that we know is a priority for CLHIA to address. And also temporary changes in medication. So these are kind of the primary areas that we looked at. So I'm just going to go through this table once again, or not once again. I've gone through it many times, trust me. I'm just going to go through this table with you, and there are 2 pages to this table. And I'm going to run through them reasonably quickly, but again, you'll have a chance to look at them in more detail when you get a copy of the slide deck, and I'm happy to speak one-on-one. We know that payers have a prior authorization advisory committee. They may call it something different, but that's really what it is. It's to look at particularly specialty drugs, and in some cases high volume drugs, to decide whether or not that product should be included in the formulary, and what, if it is, then what requirements should be assigned to that for prior authorization. And so I want to make it really clear that in no way, shape, or form does PAFA or SPA dare to interfere in what a payer decides is their criteria for a specialty medication to be reimbursed. All we're saying for this requirement is that there needs to be a cross-functional team with access to additional expertise in place in order to review claims or to review products with the potential for reimbursement. And I don't think there's any payer that doesn't have this, but it was important to acknowledge that this is really a part of best practices. In terms of a criteria for reimbursement, we wanted to stress that there shouldn't just be one, shouldn't just be the Canadian Drug Agency or what's happening with the provincial reviews, that there should be a number of factors considered when creating the criteria. It's up to each individual payer to determine what those different resources are. In terms of information about prior authorization to plan members or claimants, patients, we want to make sure that the information that's available is in plain language and it is in an accessible format. Now, accessibility isn't just a nice to have, it's actually a legal requirement, and there are significant 6-figure fines for those organizations that do not comply with accessibility laws. Now, most don't. I know this because that's my daughter's area of specialty, which is a constant source of frustration for her. It is important, however, that any payer not only consider plain language, but also consider individuals that have different needs. And that's why we believe that it's really important to have that accessible format requirement there. In terms of communications, we have often heard that patients, given their condition and the fact that they're not familiar with the claims process, that they don't always know the questions to ask or don't always get the right information. So we think it's really important that they be permitted to designate an individual with a specialty in this area to communicate either with them or on their behalf, whether it be a healthcare professional or drug access navigator or patient support. And in terms of communications, not surprisingly, we think that targeted and timely communications are super important for patients and designates. And again, using plain language and outlining next steps. And additional information that the plan member or patient can submit additional information if it comes up. The second part of this table addresses some additional requirements. So one of the things that actually I didn't really realize before I really got into the prior authorization processes and some of the challenges associated with it in more detail was the challenges of patients who condition maybe is exacerbated, not exasperated. They're probably exasperated too, but exacerbated. And they may temporarily be moved to a different medication that also may be prior auth medication for a short period of time until their symptoms resolve, and then they may be able to return to their initial medication. It's not saying that their initial medication wasn't appropriate. It's that people's conditions can sometimes change. I know that I have a friend, and she's a patient with Crohn's disease. She's actually spoken at the Connects Benefits Network. And I know from spending time with her that there are times when, even though she's on a biologic and she's actually on a more frequent dose than is generally available to patients, she still has an exacerbation of her condition occasionally. And then they have to change her treatment for a short period of time until her symptoms calm down. And she's actually been in this situation herself, where she had to totally reapply to get back on that original medication. And so this clause here, this requirement is built to address that, created to address that, so that individuals, if they have a change of less than 6 months, that they can just flip right back to their original medication for the duration of the approval, the original approval. We want to make sure that in most cases that there's limited information requirements on renewal, so the individual and their physician don't have to go through the whole approval process again as if they were a naive or a new patient. Changes of carrier, I mentioned that earlier, that the new payer will agree to continue to keep the patient on their approved prior auth medication for the duration of the prior carrier's original approval and renewal. This is subject, of course, to the formularies being the same and that drug being covered under the new formulary. Patient experience surveys, definitely want to see payers administer patient experience surveys to all patients or plan members, whether they're approved or declined. And we're also looking for an agreement on key performance indicators so that payers must record and report annually in terms of the percentages of claims approved, requests for additional information, the percentage declined and appealed and temporary switches, renewals, interruptions, and response times. Plus, we want to, as I said, administer those surveys and report on those results. So we're not looking to share confidential information. We're not looking to name individual carriers. What we're looking to do is get an aggregate picture of how prior authorization is serving the needs of plan members. So this is why, as I said, even on the accreditation, we don't have payers involved. And any data that's reported from a key performance indicator perspective would be confidential, and there would be no identification of that payer. It's really just to get an overall perspective on how prior authorization is functioning in Canada. And right now, we have no idea. The only people who have any idea is each individual payer, but they don't even know how they compare to other payers. So a good idea to get some benchmarking. So the other thing that we looked at, and I mentioned earlier, was timelines. So I want to look at this a little bit in a little bit more detail. We set some timelines and we divided it between urgent and non-urgent claims. So when we look at urgent claims, obviously we needed to define that. So urgent claims would be any oncology or oncology related medications or diagnostics, and any requests for temporary switching or adjunct therapy to an existing prior auth approved medication because of a temporary change in medication. And so there's certainly a need for addressing an urgent claim in a shorter period of time. And based on discussions with experts in this area, we developed these timelines. So certainly an acknowledgement of the receipt of a claim and any initial documentation that's required, plus an estimated timeline for response. We expect that within 24 hours for urgent claims and within 2 business days for non-urgent claims. Notice of outstanding additional information. Again, responding back within 24 hours and 4 business days. A notice of approval or denial of claim once all the information is in within 24 hours and 4 business days for non-urgent claims. Again, that's after all the outstanding information is received. And if it is denied, it should include details of options for an appeal, because often people don't realize that they have the option to appeal. Notice of additional time requirements for payer review. So if they say the payer decides to get consultation from an additional medical expert, and that's going to take some time, that the patient should be aware of that, the plan member. And again, should be done quickly for urgent claims and within a reasonable period of time for non-urgent claims. And the second part of this table is regarding notice of additional time requirements for payer review or external consultation. I think maybe that was a repeat of the last time. I did repeat that, so it must be super important. I'll make sure I take that out of the deck before it's distributed. And claim renewal, so notice of upcoming renewal. And I think this is pretty standard practice. Usually I think there's at least 2 months a notification when the claim is going to be reviewed to see whether or not that individual will be approved for an additional period of time. Inquiries or responses to queries about the claims process, appeals, or details of prior auth requirements within 24 hours. And patient experience surveys should be at least administered or actually sent out with a request within 24 hours of notification. So once an individual is either declined or approved, that within 24 hours, a request is made for a patient experience survey. We all know that with time, you kind of lose some of the details of your experiences. It doesn't matter whether it's prior authorization or something else. So it's important to get that information or that request for information out to people within a short period of time. So I'm going to go on now to electronic prior authorization, but I am certainly happy to take questions on the administration side of things if anybody does have any questions. And I'll just take a quick sip of my coffee. No questions. I've covered everything. Great. Let's take a look at electronic prior authorization. Now, I'm fully aware that there isn't any carrier at the moment that is delivering electronic prior authorization or accepting claims through electronic prior authorization. However, it's not far away. My intelligence tells me, my market intelligence tells me that sometime in the second half of this year, we should see the first iteration of electronic prior authorization in Canada come to market. So what is our goal in adding this now when electronic prior authorization isn't really available in Canada? Well, it's really important to be prepared. We know that electronic prior authorization is coming. We know it's the gold standard of prior auth adjudication. And so it's important to set that out there as a goal for payers to reach to. Once electronic prior authorization is live, payers have that option. Well, they have the option to begin to go down that road now, but once they have the option to actually implement, then it will reduce the administration burden, improve timelines for patients to access their medications, and encourage payers to adopt EPA. And it will also recognize those who've moved to EPA. So part of this program is to really raise the bar and give payers something to reach for. At the same time, and I know most of the people on the line today are advisors, it's also an opportunity for you to ask your insurers, your payers, and say, what are your plans for electronic prior authorization? We know this is the gold standard. We know that at least one carrier is well on their way to adopting electronic prior authorization in 2025. Where are you in this process? So I think that it really does help to push the industry forward. We know, as I mentioned earlier, there are time savings and timelier access when EPA is implemented, and this has been well documented in the US. The research that we sourced is in the appendices for the program guide, which is available for download from my website. And that's where I've taken this presentation from as well. The benefits include lower administration burden and lower cost, and that's to everyone, including payers, and of course that translates to lower cost for plan sponsors. And something that you may not think about, because when you first think about improving the process for prior authorization, particularly electronic prior authorization, is the side benefits, not an immediate thought. It's the analytics. So the analytics that will be available through electronic prior authorization will really help shape internal reimbursement strategies and develop key external performance indicators. So for example, and it's already been done on a pilot basis, health outcomes data can be evaluated. The example, and this is the example, it was on migraine medications, and it was evaluating self-evaluation from patients, the average number of migraine days per month. And what was found is that when those individuals pre and post migraine medication reported significantly lower migraines. And that's something that we can do with EPA. You can do it manually, but it takes much, much longer. It can take months instead of hours or days. So really that health outcomes data, I think, is going to be a really big benefit to electronic prior authorization. And it'll really demonstrate the value of medication in the workplace setting. So that's going to help inform and assist in product listing reviews to determine whether a product should be available. It may be available on a trial. I'm just saying this out off my own experience, not that anybody's mentioned this, but it could be that a product is available on a trial basis while the insurer evaluates real-world evidence in the workplace setting of a pre and post medication to determine symptoms, productivity, days lost, things like that. And it will also inform product listing agreement. So with that value that product offers in terms of patient outcomes, then there's certainly more evidence to negotiate enhanced product listing agreements. And we've heard for many years about health outcomes-based product listing agreements. And I think what we'll see is more of those will come as EPA is implemented. Let's look at a couple of tables here that are taken from the program guide. PA forms must be available online to plan members under an EPA arrangement and to their healthcare practitioners, patient support programs, and drug access navigators. Right now, claim forms, generally speaking, some are available online, have to be downloaded, printed off, and completed manually. With OKRX, I know now that there are a number of, certainly more than a handful of claim forms that are on their system, on their EPA platform. And as of today, my understanding is that of those claim forms that are on their platform, the patient support and drug access navigators can start those claim forms online, collect signatures, attach additional patient information and medical records, and that claim can all be completed online, but then it still has to be mailed and faxed to the insurer. So what we're looking for is an extension of that so that the forms will actually be not just available online, but they'll also be able to be, the completed forms will be able to be submitted online. In terms of accessibility, again, we want to make sure that all EPA solution providers and payer claim forms must meet accessibility requirements. The last time I looked, and this was a little while ago, it was maybe about 8 months ago, most of them didn't. And again, they can be fined quite heavily for that, in the six figures. Claim form completion and submission. So an end-to-end EPA where claim forms are completed electronically through an EPA provider, and then they're electronically submitted through a secure application programming interface, which basically allows two pieces of software to exchange information. They should be able to be submitted to the payers and attach electronic medical records. Because we have so many different EMR systems in Canada, this can be challenging because there are significant requirements, protection of data, security of web-based information. There's a lot of requirements that have to be met in order to gain access or transfer information from an electronic medical record electronically. But there are agreements in place for several of the EMRs now. So some of this is happening already. The payer also must be able to send and receive communications through an APA solutions provider, so no more mail-in fax. And claim status inquiries, the payer must make claim status available to their patients and their designate through the EPA portal. So no more this phone and fax and mail. Again, we're looking for an online patient experience survey for patients that are have the advantage of an EPA process for their claims. And again, we're looking for some key performance indicators in terms of approvals, denials, etc. So that's electronic prior authorization. And when we get there, we will be able to also offer a level 3 accreditation for those payers that have achieved both an administration and an EPA accreditation. I don't think the administration accreditation will go away because there still are certain elements. It'll be changed, but there still will be elements that will be required from an administrative perspective. But I think it's a great opportunity for plan payers that they can achieve 3 different levels of accreditation through the prior authorization program. Once they have achieved accreditation, they can use the PAFA branding. And so from an advisor perspective, if you see a proposal or a renewal come through with a PAFA accreditation branding, you know that that payer has met certain standards with respect to prior authorization, administration, and communication. And then you'll be able to refer back to the guide to find out what that means exactly. That'll make it easier for you to provide recommendations to your clients on who has the most efficient processes. And I know that this has been quite challenging for some advisors. We've heard from advisors where they just can't hold on to that prior authorization requirement, and they lose that requirement because of arbitration. So this will definitely help them justify the prior authorization and ensure that best practices are being adhered to. So where are our future opportunities? Certainly in terms of provider relationships for physicians, something that's already taking place in the US is something called gold carding. And it's an accelerated approval for claims from prescribers who've already demonstrated that their approval percentages are high, and that that the claims that they're submitting or their patients are submitting have high approval rates. So for example, if one physician has, say, 95% or 98% of the claims that their patients make are approved, and another physician has, say, only 60%, then that physician whose patients have roughly a 98 or a very high percentage of approval ratings, approvals, then they would get that gold carding, say over a payer that, or sorry, over a prescriber. There's lots of P's in this discussion. Um, uh, they would have not received gold carding if they had a lower approval rating. So that's something that potentially could happen in the future. It's US is, as you know, is a lot bigger market, and that's certainly been one concern expressed about bringing this up into Canada. But with the increasing number of prior authorization drugs or specialty drugs, this is something that could be considered in the future. And in terms of automated adjudication, that's another opportunity in electronic prior authorization. I think we're going to see things shift in prior authorization in Canada from an electronic prior authorization perspective. So right, to go off slide a little bit, right now everything is forms based. So when the EPA provider is setting their system up, when a drug access navigator or a physician's office or a patient support program goes into that EPA software, they're actually calling up, say, the Sun Life or the Canada Life or the Manulife or the Alberta Blue Cross form. It's laid out, it might be laid out a little differently, but all of the information is taken directly from their form for that particular product, for that particular indication. Eventually, those forms will go away. That's going to be in a future iteration of EPA. Not sure how long that will take, but that's my information, is that that's really where EPA needs to head. And I think it's the way it's done in the US, so that it's more of it's a different type of algorithms that are built into the system so that the claim form itself doesn't pop up. It will then make it easier to complete EPA forms as well. They'll be more intuitive. So back to the slide deck on automated adjudication. So when would you get automated adjudication, and what does that mean? Well, it's really a fast track turnaround and approval process where most claims would be adjudicated without any manual review. So right now, what we're talking about is the first iteration of EPA, is that claim goes into the payer electronically, but then somebody's still going to review that manually. And that's when you start to get the time. And we know from years ago, from those of us around that were around before the PBMs and the drug cards came into being, when you went into your pharmacy, you had to pay for that product. And then you went back, saved up a few receipts, filled out the claim form, mailed them in. That all takes time. Depending on how many people were on vacation, how many claims were coming at the time, the turnaround time on claims could be delayed. And I remember as a group rep, always getting questions about, what's your turnaround time? Is there a problem? How many days is the turnaround time? Is it 2 days? Is it 11 days? Are they backed up because of the holidays? Is it 14 days? And it was always a very competitive and a very stressful thing to worry about what your turnaround time was. So we're seeing that in prior authorization. It's the same situation. It's just for high cost drugs, which is, it's a bigger stake. So what we really will see with that automated adjudication is a system very similar in terms of timing that we see already with most of our non-specialty drugs. That will mean that once that claim form is completed, that it will be adjudicated without manual review, and there will either be an automatic approval, or if it's denied, or it could be that it's not denied, but it needs further investigation or further information. So it'll be much, much quicker. So I think that sort of leap in terms of timelines and efficiencies will be very similar to what we saw when PBMs came into being and the drug cards were available. Not quite as quick, but it'll be a lot quicker. Usually, I think we're looking at these for, say, high volume, moderately priced claims with clear criterion for eligibility. And a good example would be the GLP-1s. They've also, as you know, created a significant burden um, on adjudicators, and they've definitely had to hire new staff at the payer offices to adjudicate these claims because it's put a lot of pressure on the system. And of course, when you're hiring people to adjudicate claims, then that also adds to the bottom line. It adds to the expense factor and to the cost of adjudicating claims. So let's look a little bit at the timeline for member accreditation. We're still working on the application forms, and they should be available and finalized by March 2025. Those applications will be available on request, and our website will be updated to reflect that. Submissions from payers for accreditation will be open as of May 2025. And it'll only be reviewed by the accreditation panel, which will be made up of individuals not from the payer community. And we will provide written notification and feedback. Electronic, I should say, but it will be notification and feedback. We will also be recognizing not just members and associate members, and that is actually coming out in March. Our first group of members and associate members will be announced, and we already have close to half a dozen on board. We will be also announcing the payers that are accredited too. And so we'll have, as we develop over time, we're going to be having some member and associate member only events, and we'll probably have one of those big fancy dinners to award accreditation to payers and things like that. So it's early days yet. We'll get there. And branding and recognition, as I mentioned, certainly payers can use the branding that we have developed for them so that they can be recognized as accredited under PAFA. And then, of course, the annual reporting. So those are things that we're working on that will be coming up. We expect that the survey, and it will be a total industry survey, by the way. So anyone will be able to participate. So we'll get that out as to as wide a group of stakeholders as we possibly can. And those stakeholders will be able to complete that survey. There'll be a section for each individual stakeholder group, and then we'll be able to produce results of that publicly. We'll have another one of these webinars to share the results, and we'll have some individuals speaking to different aspects of the survey. And of course, we'll also be inviting members and associate members, as well as any payers that are accredited, to participate in providing quotes to the survey, providing input into questions, and generally just getting involved. I've gotten ahead of myself on the slide deck, so these are some of the elements that will be included in the reporting and industry survey, not just the survey results per se, but we'll be also taking a high-level look at the current Canadian landscape for prior authorization. We'll look at updates and changes to the framework and accreditation program. So part of the responsibility of the advisory board is to take a look at least annually at the program guide and make any updates or changes that are appropriate based on what's happening in the current environment. We'll look at members and associate members, new and renewing, accredited payers, that as I mentioned early, the PAFA management. So although we've discussed that already in webinar number 2, we'll look at that again and confirm who the individuals are who are involved. Over time, those individuals, some of those individuals will change to make room for new people. And then once we have a sufficient volume of payers who are accredited, we'll be able to provide those reporting results we talked about in terms of aggregate anonymous results from payers regarding their reporting and their patient surveys. And so that's coming this fall. I wanted to just close off. We just have a couple more slides here on just emphasizing some of the key benefits of change in prior authorization in Canada. From a patient perspective, I think bottom line is we're looking at getting people healthier, whether they're plan members or patients and dependents. Making the whole prior authorization system easier, more transparent, and easier to access information. That the claims process is easier, it's quicker for patients to access their medication. And as a result, if you can obviously get people on medication quicker, they're going to be more productive and you're going to see less absenteeism. And overall, happier, healthier, more satisfied employees with higher productivity and better retention. From a payer perspective, um, really, they can see some big advantages in lower costs and better data, not only for their own use, but to share, to get an aggregate picture of prior authorization in Canada, which will also benefit them as well. They will experience a lower administration costs and a more efficient system. And of course, those data analytics that I mentioned to evaluate health outcomes and how patients are doing over time on product, and to negotiate PLAs. And of course, better health outcomes for plan members mean lower disability costs or the risk of disability costs. For advisors and plan sponsors, I kind of group these together, so please forgive me, but definitely more value to plan sponsors, and that results in good news for advisors. Um, both plan sponsors, I know sometimes plan sponsors get involved, but advisors get involved quite a bit on prior auth claims. So less time assisting in challenging prior auth claims. You only get involved in the tough ones. Easier to compare payers at renewal and in market surveys. You know whether they're members, you know whether they're accredited, and lower admin costs for your clients, and confidence in listing decisions that they're being made based on effectiveness and value that can be measured. For healthcare professionals and patient support, which obviously is critically important because particularly for healthcare professionals, if they're spending a lot of time on prior auth administration, they're not spending time with more patients. And we know what the waiting lists are like to get in to see a specialist. I've had an appointment, I think I've been waiting 8 months or more to get an appointment with a dermatologist. So it's frustrating. And when I know that dermatologists and other professionals are spending time on prior auth claims, then it's taking longer to get to see people like myself who are waiting. Easier access to information, so websites that are clearer, more efficient use of their time, lower admin costs in their office because it's often physician staff and obviously the patient support programs, their staff, they can be looking at a more efficient system to handle the increasing volume of prior auth claims coming across their desk. And they can be more efficient at helping patients and plan members through the claims process. So we're looking at benefits all around. There really isn't a downside. So I just want to stress as I end that it's so important to work together, that I'm not looking at this as a one-man band show, i.e. the Denise show. This is really something that we want everybody to get involved with, whether you're a payer, you're a patient group, you're a patient support, you're a medical professional, a pharmacist, an advisor, a plan sponsor. Please work with us. We want to engage everyone and realize some of the benefits that we've talked about in time, costs, and improved metrics to evaluate outcomes for patients. So today we've looked at the framework and we've looked at the reporting and the industry survey. And I'd like to thank you for being here. Without doing a full run, I think I'm just about right on time, so that's great. And now I'd like to invite questions from you, and I'd like to invite Alan Birch and Shanta to come back to me. There we go, and join us for our discussion. So we have a few questions prepared, and I see that there's a little something here from Abby. More and more advocacy is needed these days, that's for sure. Well, thanks very much for that comment. It's nice to know that our efforts are worthwhile. So thanks for that. And please keep the questions or comments coming. We did prepare a few questions. Shanta, Alan, and I met yesterday, and I put a few questions together. So one of the things I'd like to ask from your perspective, because you were both on the working group, and I didn't read your bios out, but everybody will have received your bios. I'll just say that Shanta, as well as her position with Sensora, which was Innomar Strategies, she has lots of experience that provided great value to us in our working group. She's led multiple initiatives to streamline processes and enhance patient support services. And she's also served on the board of the Canadian Association for Healthcare Reimbursement and participates in presentations at industry conferences. So thanks for being with us, Shanta. And I know, Alan, you joined us for our first panel discussion after or during our first webinar. And many of you may know Alan or have seen him from the first webinar. Uh, Alan started his life as a pharmacy tech and then moved on to being a drug access navigator and the founder of Drug Access Canada, which provides assistance to healthcare professionals in understanding how to access product and services. And Alan has been with Centrix Health, which is a patient support program since 2021, and manages the Haven Oncology Patient Support Program. So he's still working in that high stress environment of oncology. And I've heard some of the horror stories that he's had in trying to get access for patients for patients to their medication. So maybe I can ask both of you why it was important for you to be involved in the process of developing this framework for prior authorization. I know you've been involved in other aspects of simplified prior auth, but both of you I know are real keeners when it comes to this guide and this program. So maybe you can talk each a little bit about that. I'm going to ask Alan first, since his last name begins with B.
Sure. Thanks, Denise. So thanks so much for having Shanta and I on for this. There's a lot of things I could say. I could probably go on for quite a while just to explain why this is so important. I think you outlined through your slides quite a bit of what this could become, like standardization, expectations on turnaround times, clear criteria. As someone who has filled out hundreds and hundreds of prior authorization forms over the years, it is different per payer. It's confusing for patients. It's not transparent. I wanted to be part of this to at least get a foot in the right direction. I think a lot of the stuff that you talked about in your slides, Denise, like those are things that are just common sense that we need to do as soon as possible. It'd be great to have them all available as soon as possible to help more patients. I see everything, all of this from my background as a healthcare provider, like the ability to have a 1-day approval for a prior authorization for a cancer patient. That's a lot less worry for them. So it's a lot of these steps I think are so critical, and I really hope that we can move them all forward, just even if it's not all of them, but to implement some of these changes would be a huge impact and benefit to patients and clinicians.
And I think that, thank you, Alan. And I think it's important to say that many of these practices may already be happening, but some of them aren't. And if we can get a better idea of which payers are following these practices, then I think it makes it a lot easier to help guide advisors and plan sponsors in their decision making. Shanta, should I repeat the question?
I think I've got it. I think I've got it. So thanks again, Denise, for asking me on this panel. And I agree with many of Alan's statements that he made. One of the reasons that myself and Innomar decided to participate and work really closely with you on this is the elevation of this as such an environment that has grown, and I won't say unexpectedly, but I don't think anybody could have, to your point, when you went into the pharmacy and, I would have been there and I would have filled out your prescription and charged you the money. You could afford it at that point in time. You could have afforded the $50, maybe even the $100 for, very expensive medication at the time. But with the innovation that came with the biologics and with the specialty drugs, the administrative departments in the payers weren't equipped to deal with the volume that was coming. But from a payer perspective, it's only one piece of what they do, and I think this program helps elevate the importance of moving forward, and whatever that looks like from wherever the various payers are in terms of their own strategies and in terms of their own you know roadmaps in terms of technology and digitization and EPA and all of that. This helps elevate the importance of this piece of it. And so I think that that's one of the really important things, and one of the great things that this will do is elevate that conversation level.
Yeah, thanks very much, Sean. How does the framework resonate with what you've experienced working in drug navigation, patient support, pharmacy? So how does it really resonate? Alan, I'll let you go first.
Yeah, a lot of the things that could be implemented, they really remove a lot of the barriers and fear factors that patients experience. Everything you mentioned, Denise, just going back to the slides, those are all things that I've dealt with so many times with patients. We have to do your renewal as far in advance as we can to make sure that there's time for it to be processed so that when the original approval is expired, there's no gap in treatment. There would be times where a patient would come in needing a renewal in their current authorizations expiring in a week or less than a week or already expired. So we have to get an emergency approval as fast as we can. But if it's going to take 2 weeks, let's say it's 10 business days, can the patient afford 2 weeks of this cancer medication in the meantime? If it was a 24-hour turnaround time to get that approval, that fear factor wouldn't be an issue for that patient, right? So like that's why it's so important. These things resonate so much with me because I've been through them so many times, right? Like I think coming back to like cancer patients, that's my forte. I don't want them to have to worry about accessing their drug and is my insurance going to cover it instead of their cancer, right? Like they really should be focusing on getting better and all the other things that come with their disease as opposed to the paperwork required. Did I get the signatures done? Is this going to be approved in the end because I don't know the criteria of my insurance? So it definitely resonates very strongly. Yeah, so I really look forward to this becoming the standard across the industry.
Great, thanks very much. Yeah, I know we've talked a lot about some of your experiences, and it seems bizarre that somebody would be just about out of their medication, and are they not given advance notice that they're going to need to renew their approvals? Or I think that's the standard, isn't it? People are given advance notice.
So there's so many times I would have a patient bring a fax to me or a letter they got in the mail, and they would say, it's 3 pages long. I don't know what this means. So they generally, and I've seen these letters, they might say one of the sentences is your coverage will lapse on this particular date, and it's in English, right? So I worked in North York. Lots of patients here were Russian or, had all sorts of main other tongues that they spoke at home. They didn't know what those things meant, so they would not think it was the most important thing to tackle. So they might have had the letter for a month, but to them it's like, well, I have so many other things going on. Surely they wouldn't cut me off of my drug. And then they bring the letter to me and I'm like, oh no, we have to get on this right away.
Panic.
Yeah, but they didn't realize. So it's very understandable when you have so many other things going on that this letter is not the most important thing in the world to them.
Yeah. No, I think that's a really good point. And I know in the discussions that we had is that one of the thing was we talked a lot about is language, plain language. Like, I hate to use this term, but dumb it down, like make it super simple, because I think often working in this field in the benefits private healthcare sector, we just, throw out words and acronyms but people don't understand. They don't even understand what benefits they have, let alone, what the prior authorization process is all about. Like, it's Dutch to them. They don't know. Sorry about the use, anybody who's from Holland, I apologize for using the word Dutch, but they just don't understand. Yeah.
Yeah, I had patients who would say, I would say you have a copay of 10%, and they would say, what is that? What is a
What is a
copay?
copay?
We
Yeah.
take it for granted that we know these things.
Yeah, no, absolutely. Yeah. And particularly if they're relatively new immigrants to Canada, even if they do speak English, they may have no idea what group benefits are. And I don't know how many people know this, but I spent time growing up in the UK, although I was born in Canada. And when I came here, I got hired to be a service rep in group insurance. And hell, I didn't even know what group insurance was. I was used to the National Health Service in England. So I was like, what the hell is this? I took the job anyway, because hey, it was a job, right? And here I am. And that was back in the mid 80s. So yeah, even if people speak English, they don't necessarily know what this is. Yeah, that's a really good point. Shanta, what about you? What about your experience in patient support and pharmacy? And how does the framework resonate with some of your experiences?
So I think it's funny because I was listening to Alan there, and one of my first experiences when I moved from, when you finish pharmacy school and you go as a pharmacist, and you plug numbers into a system and you don't actually understand what they mean. So I think that the entire world of benefits and people understanding what their benefits are and what their compensation is, and I use this example in presentations. If I ask, a room full of people, what is your vision coverage? 90% of them know exactly how much they have to put towards glasses. If I ask them what the design of their drug benefit is, they don't have a clue. So they might say, well, it's around 80%, I think. Yeah, I don't know. I just go into the pharmacy and the pharmacy takes care of it. So I think that that's, a lot of the administrative pieces of this, of course, resonate with me because I'm in a, heavily administrative environment. And even, you put all of these best practices into place, you're still, everything sort of lives or dies by the process and being able to implement the process. So a lot of these pieces that are part of the accreditation speak to improving that and speak to, like if you can automate certain things, if you can bring information in, if you can have systems speak to other systems across the way. And I think that that's, to Alan's point, it is the patient at the center of this who hasn't a clue. And I think that that is where the patient support programs and their single point of contact that they have, regardless of the therapeutic category and regardless of where they are in their treatment journey, it gives them that sort of center where they can get the explanation for it and they can understand it. So we spend a lot of time, our frontline caseworkers spend a lot of time explaining people's benefits to them, because they've never dealt with them before. So I think that there's a real opportunity, outside of this to really communicate with people what their benefits are, how their benefits work, and the more similar you can make benefits, not in the offering but in the intent of them. From insurer to insurer, when a patient switches, and I mean that is one of the big challenges we run into,
Yeah.
is we currently are dealing with a case right now for a high cost drug, where the plan sponsor completely changed the benefits, and the drug is no longer covered, and so that becomes a real gap in that patient's journey, and they don't know where to turn, so they turn to us. And if they're not involved with the patient support programs, because not all drugs are covered by patient support programs, that puts the burden usually on the pharmacy. So then it's the pharmacy that's dealing with that. Their community pharmacy, they go in, like Alan says, you have letters, you have things, and they go in and they try to get,
Yeah.
explanations from there. And I really want to highlight here, just it's not, none of us created that complexity by design. It is just the growth, the resource challenges. You said, okay, well, we want payer forms to be turned around in 24 hours. And there's probably a few payers on the line who are going, yeah, we would like that too. So it's not as if they haven't considered everything that has been,
Yeah.
that we're bringing up in this. It is just, again, bringing that to the forefront. And now maybe we can get traction to do something and get them the resources and the help and the conversations for them to move forward with it.
Yeah, I think you make a really good point, and the prior authorization process has really grown organically over time. So it was never designed with like, okay, let's put this here, and these are going to be some of our issues, and blah 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 blah. I remember when it was like one or two drugs, and it was like then they did some analysis and they said, well, 85%, 90% of these claims are getting approved anyway. Is it really worth it? So I think in general terms, I think we all agree that there's a place for prior authorization. The challenge is, as you said, it's grown organically, and everybody's doing something a little bit different. And it's very confusing, and we really need just a complete overhaul. So this is what we're trying to try and get some consensus on some basic standards and practices as a baseline so that we can make things better going forward. I did want to get into a bit of a discussion about why we split the accreditation into two parts, because I think it's important to have that discussion, because it may just be, oh, well, why not just be PAFA accredited? But maybe you can speak to that a little bit, because we do have right now a manual system, but obviously EPA is where we all want to go.
Yeah, well, I think you had made a very good point. EPA is the kind of the end goal, and it's going to take a while to get there. I think we would all love to have it right now. Back in the hospital here in Ontario, we would use the SADI portal for all of our public covered patients, right? So we're used to using electronic prior authorization on the public side now in the oncology space. So it would be great to get to that point at some one day, right, with our private insurers. But in the meantime, like you had listed on your slides, again, like there are so many steps with administration that can be improved as well. Like the transparency, things like that. Anything, honestly, would be a help, even if it's not, you can't get them all. Some of them they already do, like having specialists review prior authorization. That's of course, and lots of drugs do need prior authorization. It makes sense to still have it, but I think there definitely can be efficiencies brought in, goals for everyone to follow and aim for. And one of the things that I talk a lot about insurance to patient groups and healthcare professionals, it is very, I call it fragmented. Like everyone, like you said, does it their own way. They have their own version of everything. It would be great to simplify where we can, where it makes sense, where can we align things so that if we have to explain how private insurance works to a patient, there is at least something that's consistent across the board. Because right now the forms are all different. Some drugs require prior auth with one insurer, not with another. There's just so much variety right now. I'm a big proponent of consolidation. If we can have one portal, enter the information like OKRX, something like that, and then on the back end, it shoots it to the appropriate payer and modifies it, puts it into the right format. But from the HCP perspective, it's just entering information. Something like that, and improving the administration there is at least a step forward, right? That's something we don't have. I would be happy with anything that would be a little better than we have currently.
Not that you're a desperate man or anything. You do sound kind of desperate.
Well,
But I
it's
guess
gotten,
that shows that level of frustration from working
yeah.
on this for years.
But it's like you said, Denise, like it started small, it's gotten bigger and bigger and bigger. Unless we stop it, it's just going to get worse and worse.
Worse.
Let's improve things now and get things rolling.
Yeah. 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 And we're not saying, as I said earlier, we're not saying, everybody has to have the same criteria. We get that. That's not that I necessarily agree with it, but it's not, and we know it's non-negotiable for payers. They see that as their competitive edge. Although I don't think people really understand the nuances of it, but regardless, we'll just give them that one as a win. There are ways that we should be able to agree as an industry on some basic practices. And we know that, not every single claim is going to be responded to in 24 hours. We know that, but in general, that's the standard. That's what you're reaching towards. That's where the majority of claims fall into if they're urgent claims. I'll give you a chance to have a say, Shanta.
No, I was just going to say that, what I really like about and I like the separation into you've got the two different levels here because, yeah, EPA itself is a whole other discussion and it requires, like Alan spoke about SADI, there's the BC Special Authorization Portal as well. And there's other, smaller initiatives when it comes to, and we use the word electronic cautiously, because it's not an end-to-end solution like you will see in the United States. One of the challenges is that BC's is different from Ontario. So when you have major insurers that are going to have these portals, but they're different from a health provider's standpoint, whether it be a PSP or a physician or a pharmacist, you're still faced with that. Which system am I entering today, and what's my password for that system? So those we have to be thoughtful on that part of it. And to what you said, it's a longer journey on the EPA part. The administrative pieces, and you did mention this, a lot of those administrative pieces are already captured with some of the insurers, but getting the alignment, visibility to what is standard in the marketplace, and really saying that, hey, 90% of insurers have access to special authorization forms from their patients portal. Why don't you? Right. And you have that benchmarking that can happen on that side. So I really, that's the laying out of the two separate and keeping them as separate entities under the umbrella of this, I think is a good approach.
Great, thanks very much. And you both mentioned SADI and the BC program, and we did look at those when we were putting this together. And I should say that this is not just an accreditation program for private payers, it's also for public. And as soon as I get the contact information, and I'm working on it for Ontario and BC, I'll be calling them. But I think maybe you can speak a little bit more to what has changed with the implementation, certainly of, say, SADI in Ontario. I'll give you,
yeah.
why don't you take first crack at this one, Shanta?
Yeah.
Oh, we'll go Z to A this time around.
Yeah, that's right.
So I'd like to say, and I would love to say that 100% of, and of course within AMAR we have 160 programs that cross the gamut of all of the therapeutic areas. So you're dealing with different types of specialists and different groups of specialists, different office sizes. All of that has to be taken into consideration when you are utilizing SADI. And I would like to say that 100% of the physicians in Ontario have signed up for SADI and use SADI. I think it's probably closer to 30. So you do have, and from a public payer perspective, you still have the physician is still the center of care. I know we were talking about earlier in terms of, patients come to you with a letter that says my drug has been approved by my private insurance. What does this mean? In Ontario, for example, the EAP is owned by the physician. So there's other barriers there to receiving that information. The physician owns that information. The patient has to access that information through the physician. On the opposite end of the spectrum, you have the BC Special Authorities Portal, which, like SADI, is working towards making automated, and I'll put in quotes, automated decisions on simple special authorization drugs. So if it's a lower cost special authorization drug, there's a bit of an engine in the background that helps give you an immediate approval. In BC, as a resident of BC, I can actually follow the entire special authority journey on my Health Gateway app. So I can see exactly where my submission is for my drug. So you have extremes even within the public sector in terms of these, and they are portals for data entry, but not necessarily engines in the background to make the decision. So there's two sort of distinct pieces on that EPA.
Totally get that. And that was when I was talking about future opportunities. I think
exactly.
That's yeah. And Alan, what do you think about SADI?
Well, I've been to so many talks on SADI back when they were planning it, and then all the advantages. Like I still remember all the slides they would show of digital data in digital data right to their database. So there was the efficiencies. Where are we finding the efficiencies? We're not transcribing a PDF. We're not typing that in, and they can look awful sometimes, right? There can be errors made when you're transcribing content. It's electronic to electronic into their database. So there's efficiencies there. It's faster for everyone. It's more legible. There's, like you mentioned, a lot of the benefits, Denise, in having electronic data captured through a portal to your database. You don't have to have as many people, like case managers and stuff, working on these files. And then when you do have those, Sadie can just auto approve certain things if the algorithm deems it to be appropriate. So you're saving on staffing costs there. And as Shanta mentioned, you can connect it with all sorts of other apps and tools that there's all sorts of places in the future. Hospitals in Ontario all have my chart and different tools, connecting those platforms together so that a patient
Yeah.
can know what's going on and be plugged in. My drug's now approved. I'm gonna go to the pharmacy and get it. You know, there's so many advantages to having electronic data. So if we start with electronic right to the ministry and then connect it with other platforms, you know, it really is where we should be in 2025.
Yeah.
You know, I see some of the other provinces where they're still very paper-based, like in Atlantic Canada, and just, you know, how can we not do that anymore, right? It's so, we always talk about how archaic healthcare is in Canada because we fax everything still, right? If we can finally move to these portals for cost efficiencies and so many benefits, like we really should be aiming to do that and
Yeah.
finally get it done, right?
Yeah. And I think payers are getting closer. I mean, it's not a small ask. I get that. And I know that there is an upfront investment that needs to be made. But as Shanta said, you know, as this, or it was, I think it was Shanta, as this grows and grows and grows and gets bigger and bigger, then, you know, the status quo is just not acceptable. And I think payers do realize that. I've heard feedback from payers that they do realize it. I think what they can look at this as is, well, this is a way to get recognized for, you know, for doing it, you know, for for creating those admin efficiencies, or if they're already doing them, to be recognized that they are doing those things. If the current administration process, they're doing that efficiently. And when they get to EPA, that they have EPA, that they can add, this is an added attraction. I think one of the things that we do need to talk about, and I know that time's getting close to being closed off now, but I think one of the challenges, I think, from an advisor is you don't always know, or your client doesn't always know, that there are problems with the PA process. Because when you do have a serious disease that requires a specialty medication, we're talking high costs, and people can be reluctant to talk about, you know, minor conditions, let alone something that's a very serious health condition. So maybe you can talk a little bit about why or how an advisor or a plan sponsor may not actually know that there's a problem.
Yeah, so I think that, and I'm just looking at Kathy's message
Yeah,
in
I've
the chat at this,
paraphrased,
yeah.
obviously.
So it is, you know, it goes back to what you had talked about before, Denise, in terms of the competitive nature of the drug benefit. And, you know, it never used to be part of the value proposition from an insurer or an advisor to a plan sponsor. You had 2 formularies, maybe 3 formularies that you chose from, and the drugs fell into one of those buckets. It was either on all 3 or it might be on 2 of 3. And it was, you know, it was a much simpler environment at this point in time. You know, insurers now build a multitude of formularies, and whether or not a specific drug happens to be captured based on the review process that you talked about very early on, and having that review process, it's the result of having the review process that a drug may or may not be covered. Kathy's point, though, touches on, and I want to make sure, and I know we're running short on time, is the patient experience in the advocacy piece of it. And we make the assumption sometimes that patients are willing to advocate for their own health. I fundamentally want patients to do that. However, you know, going back to, you know, a piece Alan said, these are patients who are very, very sick sometimes. They're scared to lose their coverage. We've seen, you know, examples of when coverage can be changed due to somebody being on a high cost medication. So it leads to, it's a larger and a much more complex issue on how patients advocate for the coverage of a certain drug versus advocating for coverage of all drugs and how formularies are developed and what the relief mechanism is if it's not the payer itself. Is somebody else available that's not the manufacturer to cover that drug? Is it on the public listing? What is that pathway look like? And that's another very, very obtuse and sort of behind the curtain piece of not just at the insurer, but also at the employer level.
Yeah, and we really don't have any industry pooling mechanism right now that can take that burden away from particularly small employers, and ensure that under one catastrophic
Yeah.
drug program on the private side.
Whole other webinar, Denise, whole other
Yeah,
webinar.
whole other discussion. So with that, I'd like to thank both of you. You know, you've been of great assistance in putting this guide together. There's been lots of meeting, lots of reviews, lots of discussion, and without your personal experiences, we just wouldn't have been able to put this together and have it be so targeted to some of the issues that patients are facing. So I'd like to thank both of you sincerely for being with us today and for your assistance. I'd like to thank everybody who's on the line. Please consider joining as an associate member if you're an advisory group. I realize that for some advisors, the price may be a little bit prohibitive, but please, if you're a larger advisor, please consider joining. Get involved. We will be having some special events for members and associate members only. And really start asking your payers about prior authorization. Are you a member? Are you intending to apply for admin accreditation? If not, why not? There's a whole section in the guide that helps you with what questions to ask your payers when you're speaking to them about renewals or plan marketing. So thanks everybody again for attending, and please reach out to me with any questions or assistance that you may need. Happy to help. Thanks, everybody. Take care.
Thank
Thanks,
you.
Denise.
Have a good afternoon.
Bye,
Take care.
everyone.
Bye-bye.